Hello, my name is Stephanie Grant, and I am presenting the final assignment for Interprofessional Organization and System Leadership for class Nurs6053N-13. This assignment is to identify a change that is called for in my workplace and the management plan for implementation. I have chosen the implementation of a dermatology-oncology nurse navigator. So I'm going to briefly summarize some of the current issues we are facing in my workplace and describe the proposed change of the implementation of a dermatology-oncology nurse navigator to improve upon these issues, along with justifications of the change. We will discuss the type and scope of the change, the stakeholders, and the management team, as well as how the change will be communicated and ways to combat risks that may be associated with it. So background, I work in a surgical oncology dermatology office. We focus on the identification and treatment of skin cancers through either in-office excisions or micrographic Mohs surgery. As identified by the Clark Healthy Workplace Inventory, our workplace can improve upon teamwork, collaboration, and reasonable workloads. Although my specific department does not struggle with teamwork amongst ourselves, we often have to refer and collaborate with other departments and other facilities for complex cases, which is when we really start to see these issues arise. So with these types of complex cases, we've begun to see issues with communication and collaboration between departments. So there's an opportunity to improve the referral process and patient management. The workload of our current staff is maxed out. We don't have the time to appropriately manage some of these complex patients with their referrals and follow-up care in a way that is necessary to ensure the best outcomes for the patients. So a solution for these issues would be to implement a dermatology-specific cancer care navigator. This individual could ensure these complex patients get their appropriate education, testing, treatment, and follow-up care that is vital for their diagnosis, while also helping to decrease the workload for the clinical staff. So description of the change, kind of the roles and responsibilities of the nurse navigator, would be to be present at the diagnosis and discussion of the options. They would ensure patients understand the diagnosis and what options they would have, and then they would be in charge of follow-up appointments, so protocols and clearance. For surgery, if patients on a blood thinner, we have to discuss the medication with their cardiologist to hopefully hold it before surgery. If they're on warfarin, sometimes they have to get an INR or Richard's Lovenox, and all of these are issues the navigator could organize. If the patient has a different upcoming surgery, especially for total joints, they may not be allowed to have any healing areas on their body, so that would need to be coordinated as well with the orthopedic team. And then we often pre-treat areas with topical chemo, depending on the type of cancer, and this requires additional education and a specific time frame when the surgery can be completed. Referrals, they would refer as needed. If a patient refuses surgical treatment, they may need to see radiation for superficial radiation treatment, may need to consult with plastic surgery for post-operative closure planning on very large areas that we can't close in the office. In some cases, they even have to be referred out to a tertiary center if there's bone invasion present or if the areas on their eyes. And patients may need extra testing such as PET scans if they have a diagnosis of melanoma. They could also combat these other barriers, work with the patient's insurance to determine coverage, coordinate care between departments, ensure patients travel to appointments, and overnight housing if needed. The amount of time and work needed to coordinate these complex situations appropriately is unattainable without an individual dedicated to it. Something always seems to get missed. Justifications. So I wanted to start with an example with patient D. So patient D was referred to us with a very large, ulcerated, non-healing black wound on his scalp. His primary had wanted to refer him to us for months, but he had refused. He was concerned about cost and travel expenses. When we did eventually see him and biopsy that spot, it was a very deep, very concerning malignant melanoma. His treatment required several steps, appointments, and included other specialties. He needed to have a PET scan done, be seen by oncology, and be seen for surgical removal and repair in the operating room. It was not something we could do in the office. So we had set him up for his PET scan. He didn't show up to that appointment. He was concerned about the cost, but no one had told us this until we had checked on him a week later to see how it went, and the patient told us he hadn't went. So after working with the financial department, we set him up again. At that point, he was already scheduled 3 weeks out, which had delayed his treatment further. In the meantime, without us knowing, the oncology team had referred him to a tertiary center for management because they didn't think they could provide him with the appropriate care. And then the patient called us. He was very unhappy that he had to drive even further for appointments, said he couldn't afford the gas, and he became even more frustrated when we didn't know he had even been referred. So there was multiple offices with different appointments and tests without any coordination, and this led to a delay in the patient's treatment, and the patient was very unsatisfied. So if we had somebody that focused on these situations, the patient's care could have been streamlined from the beginning, and he would have been happier and had a better outcome. So the why, according to a study by Pratt Chapman et al., patient navigation is a practice that is evidence-based and is recommended to have in all cancer care settings. Having a navigator has been shown to enhance patient compliance and overall patient satisfaction by overcoming barriers to care. The most common barriers to care are transportation, cost, fear, mistrust, and the inability to coordinate care. With the implementation of this navigator, patient would have an individualized relationship with someone that was knowledgeable, could foster hope, encourage trust. It would have somebody to help them navigate cost, and wouldn't have to worry about setting up appointments. So another reason to implement this change would be to lessen the workload burden of the clinical staff. Research by Michelle et al. They had analyzed 21 nurses for over 500 hours to determine what activities they spent their time on at work. The results of that show that less than a third of the time was spent on direct patient care, with over 2/3 of the time spent on communication and care coordination. So this shows that implementing a specific person dedicated to the coordination of care would allow more time spent on direct patient care by the clinical nurses. So type and scope of change, this would be a clinical type of change. They would have a home base in dermatology, but would also work with other clinics and specialties. Scope would be a registered nurse whose focus would be on care coordination and integration. They would not be providing direct patient care. Stakeholders. Stakeholders are the people who are responsible for the change or have some sort of stake in the success of the change or may be impacted by the change. In this case, our stakeholders would be physicians, whether it's the dermatologist that was diagnosing or referring, or the physicians that we refer to. They can all be impacted by this implementation. The goal is to improve compliance and ease the transition of care, so they have a stake in that. Organizational administration, improvement in patient outcomes and the cost of the implementation. So did our outcomes improve with this change, and is cost worth the outcomes? Clinical staff, clinical staff would be the go-between, can help answer questions, concerns of the navigator, the physician, still have a role with the patients. And again, workload balance for the clinical staff. And patients and their families, arguably the most important. They are the ones who would have the most benefit from the implementation. It would improve their entire navigation through diagnosis and treatment. So the change management team, the National Institute of Health, along with a statement from the American Heart Association, have both stated that utilizing interdisciplinary teams is critical in healthcare. So by using stakeholders of the change who are already part of an interdisciplinary team, we'd be able to approach a change with different viewpoints, strategies, and ideas. So as listed here, the team for this would be the navigator, the dermatologist, clinical staff, administrative personnel, management, and then upper organizational administration. So plan for communicating change. A brief video presentation with a visualization of the expected benefits could be initialized. We could use a scenario such as with the previously described situation of patient D to allow kind of a real-life visualization of how this would be applicable into practice. And then after the presentation, open dialogue to address questions and concerns. Risk mitigation. So what problems could arise? The organization would have to consider cost. The navigator would have to be paid a fair wage, which would come out of the dermatology department's budget. But the decision to create this position would ultimately be up to the organizational leadership. They would need to consider not only the cost of the position and paying the navigator, but also the value that this position would add and the positive impact that could be made, not just on patient satisfaction, but patient outcomes. It could affect readmission rates, which therefore could be some cost savings. They would determine the necessity of the position, again, considering patient outcomes, but also with the positive impact on clinical staff. Their workload would be decreased, which could lead to improved staff satisfaction, which could impact retention. And then what problems could arise after implementation? So unforeseen circumstances, what would happen if the navigator resigned? Staff would have to be able to fill that void temporarily so it could be replaced. Final thoughts. So adding a dermatology oncology nurse navigator would improve patient outcomes, increase staff satisfaction, and add value to the organization. So that concludes my presentation. My references are all listed here. Thank you for your time. Have a great day.